Hi everyone, my name is Vinicius and I'm a family physician and PhD student at the University of Sao Paulo, Brazil. This video is to share one of my presentations that I gave at WONCA conference this year in Sydney, Australia. I truly believe that we can reach far beyond if we share knowledge as much as we can, so this is also my contribution to that goal. I'll be presenting to you some preliminary results of a scoping review we're working on regarding the problem-oriented medical record and electronic medical records in general. So the key points that I'll try to communicate during this presentation are that electronic health records with a problem-oriented approach can have a significant impact on patients, including mortality. We do not know much about benefits and harms of these systems since we do not have well-designed controlled trials. And future research should focus on the impact of these systems on patient outcomes in diverse and non-simulated settings. So Lawrence Weed was the first to propose the problem-oriented medical record as a way of systematizing the organization of information in the record and systematizing clinical reasoning upon patients' multiple and complex conditions. In his famous article, Medical Records That Guide and Teach, he argues that at present the physician has to read the entire record and then sort the data in his mind if he is to know all the patient's difficulties and the extent to which each has been analyzed. There is no evidence that he does this reliably and consistently. He and others using the record lose their way and problems get neglected, missed entirely, or treated out of context. This was written in 1968 and remains as relevant today as it was then. And a group of Canadian researchers delved deeper into the kind of information chaos described by Lawrence Weed. They focused specifically in the context of primary care. They proposed a concept model that includes 5 elements that build information chaos, and they were information overload, information underload, information scatter, information conflict, and erroneous information. And in their publication, they argue that information chaos is more than inconvenient, annoying, and frustrating. There are operational implications that can impair physician performance, increase workload, and reduce the safety and quality of care delivered. So our main motivation involves answering these 2 questions. How has the problem-oriented framework been applied to electronic health records currently in use? And what outcomes do these systems yield for professionals, patients, and healthcare services? To answer those questions, we have designed a scoping review to systematically review the literature. We searched through the Medline database, and we included studies that involved electronic health records that were currently in use and that had some feature related to the problem-oriented approach, such as a problem list, a SOAP note or any variety of it, and an episode of care structure. We excluded reviews, comments, interviews, editorials, book chapters, and we also excluded articles which were not written in Portuguese, English, or Spanish, and some of the articles were unavailable to us. And now I'd like to show you some of our main findings and next steps. So this is still an ongoing review. We still have some articles with pending analysis. We last searched for articles on October 14th, 2023. We found 325 articles through Medline and 9 through article references. With a team of 3 reviewers, we screened through the title and abstract of 320 articles. We assessed for eligibility 171 articles, of which we included 81 considering those inclusion and exclusion criteria I mentioned. And the first thing we've looked at was which features were implemented in the electronic health records used in the studies. The most studied feature was by far the problem list, followed by the episode of care structure, and finally the SOAP note or its varieties. We were also interested in what outcomes those studies were focused on. Most of the studies measured some outcome related to healthcare professionals, such as professional satisfaction, time needed to review the patient chart, or agreement rates on the problem list completion. Some studies involved some kind of outcome related to healthcare services, such as cost and documentation quality. And what most caught our attention was that patient outcomes were the least studied. In our opinion, this should be a priority, and that's why I'll focus the rest of our valuable time discussing it. So, only one of the 10 articles measured mortality after implementation of a new system. Other outcomes related to patients were present in those studies as well, such as the number of times a problem was discussed with the patient after the intervention, the number of ordered laboratory exams, and if they were aligned to current guidelines, changes in laboratory results after the intervention, emotions, opinions, and actions taken by patients after seeing their problem list, epidemiological analysis about how some patient complaints relate to others, and etc. There were others as well. And I would like to focus now on this unique study that measured mortality after the electronic health record implementation. So the study involved 3 dialysis units and almost 2,000 patients with end-stage renal disease treated by chronic maintenance hemodialysis. Okay. So the electronic health record had many interesting characteristics, including lifetime patient relevant data, which was easily available, laboratory results, dialysis data, and other relevant reports available and automatically downloaded into the database, real-time dialysis machine data, coded patient problems, links between problems and prescriptions. And one of the main features was this thorough problem list, which had all the conditions of the patient, including a section directed specifically to problems related to kidney and urinary tract. Important events and procedures were presented below in a chronological manner, and professionals also had easy access to allergies, surgical procedures, diagnostic procedures, vaccines, and hospitalizations. All laboratory results were readily available in a chronological format that facilitated comparison with previous results. And professionals also could easily set up conditional alerts involving the laboratory results. So they have progressively implemented this system in 3 dialysis units, and after a 9 years period, they've seen a consistent decrease in mortality in all units. In the graph on the left, we can see what happened to each individual unit. On the right, you can see data pulled from the 3 units and a constant decrease in mortality over the years. That corresponds to 28 per thousand reduction in mortality every 2 years. The authors looked for confusion factors such as clinical guidelines improvement, changes in treatment standards, or patient demographics, changes on staff number or staff training, but no relevant event like those was found that could explain this drop in mortality over these years. So according to the authors, what contributed to the decrease in mortality was the extensive coding of conditions and procedures, which facilitated immediate reports and continuous improvement at the point of care. Also, all relevant information for clinical decision making was always promptly available. So in conclusion, we do not know much about how these systems impact patients, either in a good way or a bad way. Talking about the future, for future research, we should investigate better through controlled trials how do problem-oriented electronic health records affect patient mortality, control of chronic diseases, prevention of diseases, diagnosis, and professional and patient interactions. I'd like to acknowledge this team of Brazilian family physicians and researchers that contributed to this study. Without them, this wouldn't be possible. And that's it. I hope you enjoyed. If you have any questions, you can leave here in the comments. I'll be happy to answer you. Have a good day.